Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Alex Lutz, the VP of Public Relations and Marketing at RUMC, Dan Ryan, the Advertising Director for the Staten Island Advance, and Dr. Joseph Muscente from our optometry clinic at RUMC. Welcome.
Thank you. Great to be here.
Through RUMC Connections, you will meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. The health of our eyes has a major impact on every area of our lives, from work and education to enjoying time with our family. Richmond University Medical Center is proud to serve Staten Island with a full range of eye and vision care services to promote better eye health. One of the fixtures you will find in our ophthalmology department also happens to be our guest of this episode. Dr. Joseph Muscente is a graduate of SUNY College of Optometry. After completing optometry school in 1994, Dr. Muscente completed his residency in hospital-based optometry, ocular disease at the FDR VA Hospital in Montrose, New York. Dr. Muscente then became a clinical instructor at the SUNY College of Optometry and a staff optometrist at the Brooklyn VA Medical Center, St. Albans VA. Now at Richmond University Medical Center, Dr. Muscente works closely with ophthalmologists, residents, and students, providing comprehensive medical eye care to all patients. In this episode, we'll discuss ocular emergencies. Eye emergencies include cuts, scratches, objects in the eye, burns, chemical exposure, and blunt injuries to the eye or eyelid. These injuries may cause visual changes, pain or discomfort, and changes to the appearance of the eye itself. Dr. Muscente will share some of the more common injuries people experience, how to treat them, and when it's time to seek medical care. So once again, welcome, Dr. Muscente.
Great, thanks.
And
Thank you.
if you could please enlighten us, what are a few signs that something could seriously be wrong with the eye?
So the word emergency is very subjective. My idea of an emergency might not be your idea of an emergency. So we have patients who sit on something very serious for 2 weeks, 3 weeks, 4 weeks because they're frightened or because they don't have the right insurance or whatever the reason may be. And then we have the patients who come in twice a week who really don't have an emergency. So it's a very subjective thing. But in general, eye emergencies usually have a couple of similar things. One is loss of vision. So if you find that all of a sudden your right eye or your left eye or both eyes all of a sudden can't see like you know you've been seeing yesterday, get to see a doctor. That could be an emergency. Pain is never good. If you have pain in either eye, usually not a good sign. You know, pain is a wake-up call, you know, in the eye, as well as, you know, I sprained my ankle. It's a wake-up call to say maybe a professional should look at this. Those are the two big things. Pain and loss of vision are the two things that we really recommend that you see an eye care professional for ASAP.
You know, when you talk about like the differences in what's considered an emergency, do you find it common that people sit on what could be a real emergency for a long time? Is that a common thing?
Unfortunately, yes. You know, and I think it's because people are frightened. You know, I think the best way to, in their minds, to conquer this emergency is to ignore it. But very often it doesn't go away, unfortunately. So they come in and sometimes it's too late. So we recommend that you're in your body since you've been born, so you know when something's not right, especially with your eyes. And it's something as simple as, you know, look out the window and cover your one eye at a time and just take a look. If something's not right or something has changed, go see a professional. It's probably a good idea, especially if you have a history of trauma, recent trauma in that eye.
Are there eye emergencies that are, I'll say, silent, have no symptoms until you actually go to a professional, like, wow, something's going on here?
Absolutely. For example, there's something called a central retinal artery occlusion, which is a visually devastating disease. Basically, the blood flow to your eye is cut off. So you lose your vision very, very quickly. Essentially, there's no pain. There's no redness. There's no itching, no burning, no tearing. Nothing that would make you say something is wrong, except the vision is gone. But God knew what he was doing when he gave us two eyes, because the other eye picks up the slack. And you don't often realize that one eye maybe is not seeing as well because the other eye is picking up the slack. And so it's not till you rub your eye or you yawn and say, wow, I can't see anything now out of my left eye. Maybe I should go see something. Yeah, and that happens really a lot. You know, patients will come in and I say, cover your left eye. and I can't see anything out of my right eye. When did you notice that? I don't know. And I look at their chart from last year, and their vision was fine. So the question is always, how did this happen, and why did it happen, and what can we do to help, if possible, at this point?
I mean, I guess some people, when you think about going to the eye doctor, you're really going for like your annual exam. You're thinking like, I'm going to make sure my vision's okay. I might need new contact lenses or to then be told you have glaucoma or you have something serious is probably like that double take that like, wow, I just thought I was coming for a routine exam.
Yeah. So glaucoma is very interesting also. I mean, we'll talk about this a little bit later, but they call it the silent thief of sight because there are no symptoms. You're not going to be red. You're not going to burn. You're not going to feel anything. It's not going to make you uncomfortable unless your pressure is really high. So patients are really, really astounded when I say, I'm sorry, you have glaucoma, and we're going to do this to help you to treat it. I myself, I hope you would agree that I know more than most people about eyes. And I was astounded when I went to my eye doctor and he said, you have glaucoma, Joe. And I was kind of like, really? I hadn't had my eyes examined in a while. Family history, should have known. Right? Should have known better. No, my vision is fine. I don't notice anything. But there are some tests in the glaucoma arena that we can do, like visual fields would tell us exactly where vision is missing. And I did lose some vision up top here on the right side. Had no idea, no clue. Okay. So it's pretty scary.
It is.
So the moral of that story is to get your eyes checked at least once a year.
Mm-hmm. And what would you say are 2 or 3 very serious eye, emergencies that you're seeing?
One of the things that we often see with trauma is retinal detachment. So when you have blunt force to the eye, it very often pulls the tissue, very thin tissue that we call the retina, off the back of the eye. That's bad. So that usually becomes a surgical case. And once the surgery's done, usually visual function isn't really restored. It's just a matter of kind of putting bandages on things so things don't get worse. So that's one that comes right to my mind. Very often at RUMC, because we're a trauma center, we see something called globe ruptures. The globe is the actual eye. Think of the eye like, a globe where you learn geography. It's round. Mm-hmm. And essentially what happens is the inside of the eye gets pushed forward and out the front of the eye. And that's a globe rupture. We see that a lot in blunt force trauma. Unfortunately, we see it in abuse cases with fists and bats and those kinds of things. We also see it in car accidents when people hit their head on the steering wheel. We've seen a couple of cases with airbags coming out real quickly and breaking and rupturing the eye. That's a medical emergency. Again, the prognosis is not really good with that. But because now the eye is wide open, it's susceptible to all kinds of infections. So they need to close it real quickly to get it back to at least looking normal, although the function is usually not really brought back.
So you're talking about the actual eyeball protruding out of the skull. That was what you're saying?
It doesn't really come out, but think of it as a hole in the eye.
Right.
So what's supposed to be behind the eye is now forward because of the trauma. So it comes forward and it gets very disorganized. And that causes a lot of problems if not fixed.
What about the old myth of like if you sneeze with your eyes open, does your eye get...
Not that I know of. I never saw any cases of that, but like don't sit too close to the TV. That's another one, right?
I mean, are there certain ocular diseases or conditions that as we get older just seem to become more prevalent?
Well, the one that comes to mind and the most popular one is definitely cataracts. Cataracts are a normal aging change. I just turned 55 and the C word was mentioned at my last exam as well. So it definitely is something that's very common. It's an ordinary change in the lens of the eye. Again, it's usually very slow, very insidious. So people really don't realize that it's happening. Mm-hmm. People tend to think that the exit signs aren't as clear on the road as I drive now. So let me go get checked. And usually it's a cataract. For the most part, cataracts are a relatively simple thing to fix with surgery. Mm-hmm. I work with Dr. David Mostafavi. He's the chief of ophthalmology at RUMC, and he's an amazing cataract surgeon. So we've seen patients go from can't see the big E to way down to the 20/20 line. And it's really a great thing. I mean, think about what you can't do if you can't see, which is pretty much anything. You can't do anything without seeing. So to be able to restore or be a part of that process to help restore a person's vision is nice. It's a great feeling for me and for the patient also.
Are there some traumas that are more common in children, you would say, than adults?
Yeah, so if you think about you're a mom. You think about the evolution of a child when they start to walk. You're kind of running in front of them, pulling everything out of their way. So falls is a big thing with kids.
Yeah.
So when they fall, it can be just a bump on the head, or it could be if they hit it in the right spot around the eye. We have a bony structure called the orbit. Okay, and that orbit houses the eyeball. Attached to that orbit are the muscles that make the eyes move. So if you fracture that by way of fall, that can cause big problems with the eyes moving. So we had a few cases in our hospital where a little guy fell, was wrestling, was imitating his favorite wrestler, him and his brother, and he basically threw himself off the dining room coffee table and landed the wrong way and fractured all of his orbit and pulled some of the muscles with it as well. But through the miracles of surgery, they actually put it all back together, and he's doing really well now. So I would say falls is a big thing, and orbital fractures. And kids do silly things sometimes. Oh, yeah. That's why they're kids, right?
So when you have a patient who's just coming in with an emergency, being in the emergency department or coming to the ophthalmology, walk us through how you diagnose that emergency.
Well, the first thing, people go to the ER first because they think they're having an emergency, and that makes perfect sense to me anyway. So we're in pretty much contact with the ER. I know I am at least once, twice, 3, 4, 5 times a day. Many times we could land the plane without even seeing the patient. But, that communication line has to be open with the ER. So very often we'll just say, send them up. And they come in. And then when you look at it, case history is really important. How did this happen? Why did this happen? What were you doing? And I always preface it with, you have to tell me the truth. Because, we unfortunately see a lot of abuse cases and that kind of thing. So, and we're mandated reporters, so we need to report awful things like that. But, when you look at the eye, you look at their vision, you take a look with the microscopes, you can often tell what's going on by looking at the retina, looking at the eye, checking their eye pressures to make sure that everything is okay or not okay. But through a regular exam, you could usually figure out why things are happening and how we can make it better.
And if you have to progress to the surgical step,
Correct.
A lot of that is done at RUMC.
Absolutely, yeah. So we have Dr. Muscente, who's there now. He's, like I said, he's the chief of opto. We have Dr. Christina Vici-Domini, who's coming on board, which is kind of exciting. We have a whole team of medical residents from SUNY Downstate Medical Center. And we now have an affiliation with the SUNY College of Optometry, which is my alma mater. So there's always someone really qualified to kind of take a look and at least point the person in the right direction.
So we've talked about, you mentioned before, we've all had kids, so you hear about the dreaded pink eye. That's probably very common. Exactly. And it always, to me, when it was pink eye, it was like, that's going to go like wildfire. Everyone's going to get. What is pink eye? Why is it so contagious? How do you treat it?
What are the myths, too?
Yeah. This is it. Listen up, guys. So pink eye is really because, it's a description. It's pink because the blood vessels dilate in the eye. And I teach my medical students and my optometry and ophthalmology students, it's got to be one of the Fab Five, okay? Allergies, bacteria, virus, inflammation, or mechanical injury. One of those 5, it has to be, or a combination of those 5. So by looking at the symptoms, when it started, it's very, well, to me it is, it's relatively easy to see why it's happening. For example, let's take allergies. Allergies don't happen just on one side of your body. Allergies happen in your entire body. So it would be really weird to have one red eye because you have an allergy, unless something got in there, of course. But so usually one eye is not an allergy. The most common one is viral. And who knows, you know, what kind of virus could be causing a viral pink eye or a viral conjunctivitis, which is the big word that we use. That's the most common. You know, you get that weepy kind of red, kind of annoying, my vision's okay, kind of an appearance, kind of look. Children are wonderful at bringing that home from school and giving it to their parents. So if I have a person in front of me who's kind of like around little kids' age, I always say, which one of your children had pink eye? And then, oh my God, I never thought of that. My daughter had it 2 weeks ago. So, of course, an eye can be red or pink because you got clocked in the eye with a softball or a baseball or a tennis racket or something. And there's also inflammatory diseases called uveitis, or an inflammatory disease called uveitis, which is inflammation inside the eye. That can make the eye red in a certain pattern as well. Dr. Nasafavi actually is a uveitis specialist. That says he's fellowship trained in uveitis. So we see a lot of patients with red eyes because of things that are going on in the rest of their body, autoimmune diseases, rheumatoid, lupus, all kinds of things like that very often cause redness as well. So in my mind, I really do this when I have a patient with red eyes or pink eye, as we call it. I go down the Fab Five in my mind. You say, which one is it? And I eliminate them, and then I say, it's got to be this. And I treat it accordingly. So that's kind of the fail-proof way of doing it. That's the way I was taught. I didn't think of that, but that's the way I was taught.
So you spent a lot of time in veterans hospitals?
I did. I was on staff at the Brooklyn VA hospital, and it has a couple of hospitals affiliated with it. There's St. Albans and Queens, and there's a veterans clinic here in Staten Island. So I was kind of bouncing between Brooklyn and Staten Island, and it's always great to serve the veteran community. So yeah, I was on staff there for quite some time. And then 9/11 happened, and I lived in Westchester at the time, and I just couldn't do it. I couldn't get over the bridges. I couldn't get there, so I had to bow out, unfortunately.
Did you start to see eye conditions that were, say, more prevalent in veterans or they're more age-related?
Yeah, when you're working at a VA hospital, you tended to see a lot of middle to elderly men when I was there. So that leads to cataracts is really popular because they're older. You tend to see glaucoma there as well because they're older. You see things related to cardiac care. Some eye problems related to cardiac issues because it was, I can say this because I'm Italian, it's an elderly, overweight Italian man population. So we had a lot of hypertensive issues and diabetes issues and a lot of eye problems associated with those things. But so yeah, it was a great experience. I enjoyed every minute of it. It was really a nice place.
Are partially detached retinas another symptom that you see with older age?
Not with older age. Usually,
Okay.
Partial detachment can happen for traumatic reasons, of course, but it could just happen sometimes, which is the scary part.
Yeah.
Sometimes there's a little imperfection in the retina, like a hole or a tear. And you don't even know it's there.
Yeah.
And then all of a sudden, it starts to make its move and get larger and pull the retina off. So that's pretty scary. So whenever you see something, no pun intended, you should really get it checked out, especially flashing lights, that kind of stuff. That's one of the things that is really important. If you see any flashing lights or sparkles, that can be dangerous. That could be a retinal detachment or something. So it needs to be looked at ASAP.
What's the most unique eye, trauma that you've witnessed over your years?
The most unique eye trauma, wow. We're looking at 27 years now. We had a case of a little girl. I don't know if this is interesting, but it was certainly heartbreaking. A little girl was in school, just like every other little kid. And this was at RUMC actually. And she bent over to pick up her pencil and she came up and she hit herself on the corner of her bookcase. And we talked a little bit about globe ruptures.
Yeah.
Well, she had a globe rupture. And she came in and she was so brave. And, she was kind of like, why can't I see out of my eye? I'll never forget that poor kid. It was just such a scary event. And, they did surgery on her and they closed it up and everything is okay now, but she lost her right eye, unfortunately. So I never forgot that.
Right.
Yeah. I don't know if that's exciting.
Pencil, I thought we were going in another direction.
Pencils are sometimes the culprit as well. Yeah. As well, yes. I agree.
Well, I guess the best, we talk about it. We always go, most people, we always try to tell people, you go for your annual physical and you go to your dentist. And I don't think people make that third jump to go to your eye doctor. It's kind of like, I'll go for my physical and occasionally I'll go to the dentist or I'll go to the dentist. But when it comes to getting your eyes checked, it's kind of like that thing that everybody puts off. And I think we've kind of highlighted the dangers of doing that. But do you commonly see, like, when you open up a chart, it's like, wow, they haven't been here in like 5 years or something?
We do, especially post-COVID. People were, people were afraid to go to the hospitals during COVID, and I'm hospital-based. I'm in the hospital, where I work. So people were putting it off because they were afraid to come. I'm okay right now. I don't see anything major happening in my eyes. So why should I go risk my life by going to RUMC? And that's unfortunate. And we've seen a lot of patients who have things now like glaucoma, that's actually progressed because they've kind of become a little bit lazy for whatever reason in having their eyes checked and their pressure monitored. But yeah, I agree. One of the things that always makes me worried is children. Before before a child goes to school, like 70% of what a child learns comes from their sense of sight. So why aren't we mandating, like children have an eye exam before they go to school? I mean, so if you have a kid who's in kindergarten and first grade and second grade, the formative years when you're learning to read and sound out things, and all of a sudden they can't see what's going on, they're not going to be able to keep up. So we're losing years of a child's education just based on the fact that they can't see what you're talking about,
Oh, that happened to us. We were lucky. Finn was sitting in the back of the classroom, and his teacher noticed that
That's great.
he's a bright kid. All of a sudden, he's not engaging, or he's losing his attention. So they notified us to go and get his eyes tested, and he had severe vision problems. But if we never knew, never said anything. He was himself. He was running around. He's a goofy kid and whatever. But I think that's great. That you would encourage getting your eyes checked early. Is there a certain age that you feel is appropriate?
I always say before they start school, unless you notice a problem. If you notice their eyes are turning in or out or up or down in any direction, get there sooner rather than later. But certainly before pre-K, kids today are amazing. Like, I don't know if it's the internet or their exposure to computers. They're reading at like age 4 now or 3. I don't think I read till that early. I don't remember honestly, but
Early 20s.
But they're really reading really early now. They're much more aware of things. So, it's important before they take a first step into school. 100% get their eyes checked, because that can really affect not only their eyesight but their education and their educational career, and what's more important than that,
In the field, I imagine, like with all the doctors we've interviewed, the field is constantly changing. I mean, when I was in elementary school, if you had bad vision, you needed glasses. And now you've got contact lenses, you've got laser, sir. I mean, there's so many options in a field that is probably changing daily.
Yeah, so the big thing now in myopia or nearsighted progression, which we see a lot now because kids are constantly on their phones and their iPads, is a contact lens called MiSight, MiSight. And it's made to help slow down the progression of myopia. I started using it in my private practice about maybe a year ago, and I have like 4 or 5 kids on it who's actually slowed it down. Because I'm seeing these patients every 6 months and their prescriptions doubling and doubling and doubling. And, is it genetic? Maybe. But is it a component of how they spend their day? Yeah, I think so. I think it's a combination of both of those things. So the new thing now, not really new, but you can use atropine drops to kind of slow down their myopia. It kind of stops their overfocusing and makes them theoretically not become as nearsighted. I think it's cruel to put atropine in kids' eyes because it makes them blurry and sensitive to light. So my heart kind of rules over that one. But they definitely need to be checked and by a pediatric optometrist or ophthalmologist who kind of specializes in that stuff, because that's something that really a specialist should look at. Kids' eyes are a little bit different, not anatomically, of course, but they have different needs than adults do. So I suggest always a pediatric person.
And you mentioned earlier that people's visions can sometimes be affected by, it's kind of like secondary to another cause that's going on. And RUMC just recently did its community health needs assessment, and we were able to see, as was kind of predicted, is that Staten Island has one of, or is not the highest with diabetes in the 5 boroughs. Mm-hmm. Talk a little bit about the connection between diabetes and vision.
So diabetes is a disease of microvasculature. What that means is it affects us very small blood vessels throughout your body. So it's not really a coincidence that eyes and kidneys and feet are the 3 things that are really affected by diabetes. So what happens in diabetes is, think of the blood vessel as a drinking straw, a long tube. And in the lining of that drinking straw, we have special cells that fit together like the pieces of a puzzle, airtight, blood tight. So diabetes affects those cells on the inside of the blood vessel, and it loosens them up. So when blood flows through, guess what? Blood flows out, and we call that a hemorrhage. We call that diabetic retinopathy. The longer the person has diabetes, the more likely they will get retinopathy. The better controlled, of course, that you are, the less likely you are to get diabetic retinopathy. But either way, you need to have your eyes checked and your pupils dilated. That's the most important part of the eye exam in a diabetic, have those pupils dilated, so we can take a really good look in the back at the retina to make sure there's no bleeding or any protein leaking out of the blood vessels or anything that could potentially cause you harm. So diabetes is so prevalent, not only here in Staten Island, but everywhere, unfortunately. And our youth is really a new victim of diabetes. for many reasons, I would assume. But so we see a lot of children now with diabetes, which is unfortunate because they have a long life ahead of them, so you got to really look at them very carefully and work with the endocrinologist or the internist and with the patient as well, because they're really in charge of their body. So it's a total overhaul, and the eye is just a reflection of what's happening in the rest of the body. You start seeing big problems behind the eyes, chances are the kidneys are on their way out, and the person's in trouble, health-wise, cardiac-wise. So, the eye is just, they say it's the window of the soul, and it's true. That when I see trouble behind the eye, it's very often everywhere else in the body as well.
Any wellness tips for adults? Like, what's the best practice? Is it an annual?
The best practice for eye health, I would say, is try to keep yourself as healthy as you possibly can. Your overall health definitely affects your eyes. If you're in good health, chances are your eyes will be relatively healthy as well. Especially with diabetics, high blood pressure patients, those are really important things for eye care people. So keep those things in check the best that you can. Regarding trauma and emergencies, just try to wear protective eyewear when you do dangerous things. I know it sounds like something simple, but people don't do it. My Uncle Joe is a mechanic, and I swear once a week for the past 25 years, I've ripped a piece of metal out of his eye. And I'm like, Uncle Joe, I've given you safety glasses. Where are they? He doesn't wear them. And most people don't until something serious happens. So that's one thing. The elderly and children are most vulnerable to this kind of things. So lighting is important, especially in an elderly patient. They might have eye issues that make them, more sensitive to a dim room than anyone else. So carpeting, you got to be careful with carpeting. If you're having carpeting with edges that are up or raised, tripping is a big thing with the elderly. We see that a lot, unfortunately, with patients who are in facilities and nursing homes, and just from their regular home, just getting up to walk to another room, they trip over something and kaboom, it all starts. But I think just general good health is always a really good thing. Good lighting is a good thing. Protective eyewear. If you're in a situation where something could potentially hurt you, I think that's really the best advice I can give.
Absolutely.
Thank you.
Yes. Well, thank you, Dr. Muscente, for joining us today.
Pleasure.
And for all that you do to keep our eyes safe and healthy.
Thank you.